Do we have any questions from the other day? Did we do all right on that quiz? Maybe? Cool. Hopefully you're starting to, it's kind of paying off for you if you're studying in advance. The quizzes you're getting some points for type of deal. They're not super hard. I mean, if you didn't study, they are, but otherwise, hopefully they're not. All right, so looks like we're on, this seems like being people's way. Yeah, maybe like that. Okay, so range of motion and joint stability is where we're at. As you can imagine, or you already know, range of motion at joints varies, right? Some joints have lots of motion and others don't. That's why we obviously can classify them as diarthrosis and amphiarthrosis and synarthrosis. Okay, that's telling us there's different degrees of movement. And the stability at each joint varies. Now, what would you think in respect to range of motion and joint stability? If a joint has lots of range of motion, would you think it's going to be more or less stable than a joint that has little motion? Right. So the more motion that's at a joint, the less stable it is. Okay? So that's one simple concept that you guys could already figure out without me telling you. So range of motion varies greatly. And some of the things that factor into this range of motion are the articular surfaces, the structures of those, okay, how much room they have to move based on the shape of how they come together. Okay, the more freely movable they are, like your shoulder joint, okay, ball and socket joint, you saw that depression that sits in, that glenoid fossa, that's not very deep. So there's not a whole lot of bony structures holding it in place. It's mostly muscles and ligaments and that type of thing. Okay, so dislocating your shoulder is fairly easy. Strength and tautness of the muscles and ligaments. Okay, the capsule, so the fibrous capsule, how tight, restricted that is. Sometimes when you damage things, it gets laid down more scar tissue, and that actually tightens up the amount of movement there. So ligaments, tendons, capsule, how tight that is makes it more stable, but it also reduces its range of motion. Okay? So generally speaking, like we said, if you have lots of motion, less stable. Not a lot of motion, it's going to be more stable. Okay? But as the ligaments and tendons tighten, so does the muscles, so you don't have as much strength in the that joint, or not the joint, but those muscles that affect that joint either. Okay, they're too tight. So there's a balance that you usually want to achieve. So in order to increase that range of motion, you need to stretch those ligaments and capsule. And that can oftentimes be uncomfortable. If somebody's had a lot of damage to, say, a shoulder, and they're starting to get quote-unquote frozen shoulder, one of the things the physical therapist is going to do, or whoever's treating them, is going to try to increase that range of motion gradually, and that's difficult. Because anytime you've ever stretched or stretched anything kind of extreme, it doesn't feel good. Okay? The term double jointed doesn't actually mean there's an extra joint. This is usually the person has very long, slack ligaments. So they have excessive movement in the joint, which would also mean that their joint is a little less stable than somebody else's who doesn't have that extra movement. Okay? Any questions on that? It's pretty simple. Okay. Bless you. Okay. So now we're moving into the skeletal system as a whole. We know the skeletal system is made up of bones, right? Bones are made up of bone tissue. What are a couple main functions of bones? Protection. Good. The whole axial skeleton that we start this week, the brain, next week will be the spinal cord. It's all protection. It's all surrounding the spinal cord or the brain to protect them. Okay? What else? It would put it down as stability, but I think I know where you're going. You have to have something for muscles to attach to, levers, in order to have a structure like being able to stand up, move around, that type of thing. Do we store anything in bones? Could we say storage? Yeah, okay. So those are some of the main ones. So support, giving us a structure. protection, movement, basically providing levers for the bones to attach to. One that I forgot. Do we know where red blood cells are produced? In the bone marrow, okay, so that's part of the bone. So blood formation, we store minerals in the bones, and sometimes we store toxins in the bones, okay? So blood formation is called hemopoiesis or hematopoiesis. Generally, when you see poiesis, it's creation of. But we store things like calcium in the bones for one, major one. Detoxification, if you're, I don't know, you'd have to live in a really old place that wasn't following many codes and they'd used lead-based paint. If you were exposed to enough lead, your body would pull that out of the blood and store it in the bones to some extent, which isn't good for you. Okay. So, we're going to look at the skeleton. Normally by this point you'd already had this in lab, but they switched it around this semester. So you have two basic parts to the skeleton. You have the axial skeleton, the central portion, which is brain, spinal cord, ribs, okay? Everything right down the center that's mostly for protection, sacrum. And then you have the appendicular, think appendages, shoulder girdle, hip, that type of thing, and everything on down from those. So regions of the skeleton: axial skeleton, appendicular skeleton. Axial, axis, everything around the center. Appendicular, think appendages. Sometimes I don't think they do it much anymore, but one of the multiple choice questions at times had been, which they give you a bone, and they'd ask you, is this part of the axial skeleton or appendicular skeleton? So most of those you could figure out. If it has to do with protecting something, it's down the center, it's axial. So ribs, vertebrae, sternum, okay? The one they like to throw out there to try to confuse you a little bit would be clavicle. What would that be? Would that be axial for protection or more appendicular for appendages, arm, leg? Appendicular, okay. How many bones do we have in a typical adult skeleton? 206, good. So, and they always put the disclaimer in a typical adult skeleton because sometimes people have extra bones. It's not it's not unheard of for somebody to have 6 lumbar vertebrae, okay? Or maybe they're missing a cervical vertebrae, or they've developed just an extra little bone somewhere else. So typically we learn that there's 206, but there can be more, there can be less. And then as we get old, when we're younger, do you think we have more bones or less bones? More, because they haven't fused together yet. So it varies with development of sesamoid bones, which can happen in the patella. Oftentimes when you stress a ligament or a tendon bad enough, it'll start to calcify, and that calcification that can be considered a bone. So we start with about 270 bones at birth. Like we said, they're not fused together. It allows that cranium to be deformed, the jaw, all that to help kind of compress the baby's head to make it down the birth canal. And then that number decreases as we start to fuse those bones together. So here's a picture of a fetal skeleton, and you can kind of see red's the actual bone, everything else is still cartilage. So you can see their bones haven't totally formed. You can see up here the soft spot. You can see these are all in multiple pieces so that it's much easier to birth the baby. Down here the pelvis hasn't formed yet. Okay. So this is the, call it yellow, off-white. That's the axial skeleton, everything right down the center, and the ribs. All their main, not all of them, the bones of the face not so much, but protection is the main thing they do. And then levers for movement would be your appendicular skeleton, shoulder girdle, pelvic girdle, okay, all the way on down to fingers and toes. So the skull, what did we do that last week? Yeah, okay, so you guys have seen the skull. How many bones do you think was in the skull? It's 100. How many? 25? More? Less? 30? 10? I don't know. Slept through that class? Skipped that lab? Okay, there's actually 22 bones. It seems like a whole lot more than that. Okay? And we know that these bones are joined by what? What are the joints that they come together? We call them sutures. Nice. See? So do enjoy the fact that lecture and lab have dovetailed a little bit. They break these 22 skull bones into two parts. We got cranial bones and we got facial bones. Okay? Cranial bones are obviously going to surround the cranial cavity that houses the brain. So generally they're going to come in contact with what's called the meninges, the connective tissue that wraps around the brain. Facial bones are going to be here in the front of the face. They're not going to have contact with the brain. So once again, it's another question that sometimes they can throw out at you. They don't have to tell you. You just have to visualize where it's at, and you can figure them out. Like if I said to you, sphenoid bone, is that going to be a cranial bone or a facial bone? Cranial, okay. Ethmoid, cranial. Parietal bone, occipital bone, temporal bone, all those are cranial bones. Maxilla, zygomatic bone. See, it's not hard. All right, surround the cranial cavity. There's 8 bones that contact the meninges. So, how many facial bones are there? 14. There we go. See? Doing math. Don't ever let them tell you that we didn't teach you math in here. They want us to actually do that. All right, so you guys pass with flying colors. These bones are in the front of the face. They support the orbit of the eye, support the teeth, form the nasal cavity. There's 14 of those bones, and they do not have direct contact with the brain / meninges. Vertebral column, which is that we start this week probably. Do you know the regions of the spine? The upper region of the spine is the cervical. Then the one in the central portion that have ribs associated with it, that's the thoracic, low back's lumbar. Okay? So that's your vertebral column. There's 5 vertebral groups: cervical, thoracic, lumbar, sacrum, and coccyx. They all put in there. Coccyx is fused to the sacrum, so I don't even know why they bother. We generally have 7 cervical vertebrae. So 7 vertebrae in the neck. How many do you think we have in the thoracic? 12. Okay. Just like we have 12 ribs. 5 in the lumbar. Now, there were 5 smaller bones that fused together to make that sacrum. So if we've done the sacrum, which I don't remember if we have or not, it's 1 bone, but it used to be 5 that are fused together now, so that's pointless to know. And then the coccyx were 4 little bones that are fused together, but they're fused together by birth, so we don't really need to know that either. Okay. So, newborn spinal curvatures. Have we heard of the terms lordosis and or kyphosis before? No, maybe? Okay. So, when the baby's born, the spine is a C-shaped, okay? It's not like the adult spine. It's in a concave shape, okay? And that curve is called a kyphosis. When the C faces forward, that's called a kyphosis, and that's the primary curvature in the newborn, okay? Because it's the first one, okay? As that baby gets older, it will keep the kyphotic curves in 2 regions. It will keep the kyphosis in the thoracic and sacral regions of the spine. Okay. So the baby's C-shaped, adults, or as you get older, your spine becomes more S-shaped. Okay? So, not a very big S, but you have a little curve this way. I'm exaggerating it. This curve here curves the other way. This curve here curves this way. And then the sacrum the other way. So it kind of alternates, zigzags back and forth. So, why would we want an S-shaped spine? Why not keep the C-shaped spine? Be a hunchback. Okay? Well, you got to kind of balance things out too. One of the reasons the babies can't stand up, one, they're not strong enough, but even as they start to get the leg strength too, if their spine hasn't started to do the S shape, everything's leaning forward. They got that big giant head, and it's leaning forward. It pulls them over every time. Stand the baby up, it'll just fall down. Don't actually do that, it's not right. But you can visualize that. But even as they get older, they fall forward. Their head, everything, it's like get the head going forward and then try to keep up with it. Okay? So as an adult, we have 4 curvatures. We introduce the lordosis, which is the secondary curvature because we see it second. It develops after birth, and that's part of the development, the leg strength, the balance, and this development of these other 2 curvatures to kind of straighten the spine out. So now they can hold their head up over their body. And it's found in the cervical and lumbar regions. Okay. So they alternate. We go for cervical lordosis, thoracic kyphosis, lumbar lordosis, sacral kyphosis. Okay. All right, so now we're going to start looking at the bone tissue that makes up these bones. So bones made up of bone tissue, that's pretty self-explanatory. We had the region that made the red blood cells in the center of the long bones. We called that the, you guys knew the name a second ago, marrow, bone marrow, okay? We're going to find cartilage on the ends of the long bones for sure. We already know that, so there's something with cartilage involved. And I think this got mentioned. Periosteum, do you remember what that was? Did I say anything about that on Thursday? It's what? It does. I don't think I said that, but that's good. It lines the inside of the bones, but it also wraps around the outside of the bone. It's the saran wrap around the bone. Okay? So the periosteum, peri means of the, osteum means bone. Okay? We talked about it with respect to the joint capsule. Okay? So when it's wrapping around a bone, if this is the bone and I wrapped it with saran wrap, that'd be periosteum. And then when it was around the joint space where the other bone was down here, this would be joint capsule. Okay? And then it would wrap around the other bone. And that's partly how they hold the bones together. One of the ways. Okay? So bone tissue. What type of tissue is bone tissue? Epithelial tissue? Nervous tissue? Connective tissue. There we go. So it's connective tissue. And it's different from other connective tissues in that its matrix is no longer gel-like. Its ground substance is no longer gel-like. It's going to be hardened. Okay? And the calcium we put into the bone is called calcium phosphate. So when you have extra calcium in your body's used up what it's needed and there's extra, the body will take it, package it as calcium phosphate, and deposit it in the bone. Okay? The bone really is a storage area for calcium. Body takes out all the calcium it needs first, the bones get it last. So that's one of the first places that it steals it from when it needs it. And it takes this calcium phosphate, puts it in the bone, and then this crystallizes to what's called hydroxyapatite. And that's the crystallized calcium phosphate that gives bone its hardness. Bone is said to be a dynamic tissue, meaning it's always changing. It's always remodeling itself. It might be making it thicker and stronger. It might be breaking it down, making it thinner and brittle. Okay? But your bones right now are different than your bones right now. Okay? Pretty deep right there, like, wow. past that one. Okay? All right, so anyway, got what we're saying. So they're always changing. They're adapting to whatever stress and whatever you do. Okay? If you do a lot of weight-bearing exercise, it's going to make your muscles stronger, but it's also going to make the bones stronger. It wouldn't do you any good to have big, thick, strong muscles and brittle bones. Okay? Think of whatever football player or big muscle-bound person you can think of, like Brock Lesnar, and put that muscle mass on Grandma. It ain't going to do a bit of good. Grandma's pecs are going to contract and her shoulder girdle is going to snap in half. Okay? So wouldn't do any good. So they kind of go together. That's a little bit why they have some of the problems now is when some of those people cheat, the muscles grow a little bit bigger and faster and stronger than the bones, and then they break, they rupture, they actually pull the tendon and it snaps off a piece of the bone that it was anchored to in their muscle. Say they tore a biceps or a triceps, well, they really usually snapped off the insertion or the origin of the muscle. So here are some bone shapes. They're not real fancy, and I really don't know why I even still have them in here. We have bones we call long bones. We've seen those. Okay, we can figure out what those are. Short bones. So if it's not a long bone, it's a short bone. Flat bones. Two examples, good ones, are the sternum, manubrium, scapula. And then basically if it doesn't fit in these, then they just call it an irregular bone. And that's the sphenoid bone. Kind of looks like a butterfly. Or the vertebrae there looks like a giraffe's head. Okay. All right, so structures of flat bones. There's not much to a flat bone. It's flat, okay? So there's just not much there. And simply what this is going to tell us is that there's two types of bones. We have spongy bone and we have compact bone. Spongy bone looks like coral. That's spongy bone, okay? Compact bone has a more solid appearance. This is compact bone. So with flat bones, you always have compact bone around a central core of spongy bone, which makes sense. You want the compact on the outside because it's not rough like this. It's not going to chew up muscles and that type of thing. So we always cover the spongy bone with compact bone. This spongy bone, these spaces in there is usually filled with red bone marrow, okay, which can help us produce red blood cells. Okay, so the internal and external surfaces are compact bone. In the middle of our little Oreo cookie there is spongy bone. Flat bones have no marrow cavity, meaning no hollowed out space for just bone marrow, but there is bone marrow kind of interspersed through these little spots in here. Okay. So that's a flat bone. It's kind of boring, not much to it. We're going to spend more of our time learning about long bones and then how long bones grow. So here's a long bone. Do we recognize what bone that is? Tibia, good. Good. Should look like a tibia to you. All right. So some things before they start coming up over there. The shaft, or the central portion, obviously when you label it on the practical, it's called the shaft. Okay? It's also known as the diaphysis. And each end of a long bone is called an epiphysis. Okay? And depending on the state of development, if this bone's still growing, right in here and right in here, you might find hyaline cartilage. And when you have that transition from bone, cartilage, bone, that's called metaphysis, okay? So that'll come up at some point. So diaphysis, we just said what that was. Metaphysis, even mentioned what that was. It's a transition area from bone to cartilage. The epiphysis is found on the ends of the bones. I think they're trying to show you right here. It looks like they're peeling back almost a single layer of something. That's that periosteum, okay, that's wrapped around the bone, so they peel that back. You can find in the bone what are called Sharpie's fibers. Sometimes they call them perpendicular fibers. Some books will call them perforating fibers. And what a Sharpie's fiber is essentially, is if we had a muscle come down here, cross this joint with a tendon, and the tendon anchors into this bone. Part of it blends into the periosteum, but then it does have some fibers that go perpendicular that penetrate into the matrix of the bone and help anchor it there, okay? And so they'll call those Sharpie's fibers perforating fibers or perpendicular fibers. We have articular cartilage. Where do we find those on long bones? The ends of the long bones, right? And sometimes they'll call it hyaline cartilage or they'll call it articular cartilage. Compact bone predominates in the diaphysis, okay? The diaphysis is primarily just compact bone. The epiphysis, the ends, is spongy bone with a little bit of compact bone over the top. Okay? In here where they're showing this yellow, that would be the marrow cavity or medullary cavity where the bone marrow is. This happens to be yellow marrow. But inside the lining here, so think of this three-dimensionally, we're inside this inner cavity, all right? There's a connective tissue that wraps around the inside and lines that, and it's called the endosteum. Skipped, okay, there we go. The endosteum. So it's like having this water bottle, and I have saran wrap wrapping on the outside, which would be the periosteum. Then I have some sort of lining on the inside that they put in there. It's like saran wrap again, and it's called the endosteum. And in between is the plastic, which in this case would be the bone tissue. Okay. Yellow marrow. In adults, your bone marrow tends to turn from red to yellow. It's more of a fatty marrow. It's not as active. So in adults, long bones, you'll find yellow marrow. Children, long bones, you'll find red marrow. And then sometimes you'll actually find little holes in the bones. And those are called nutrient foramina, where a blood vessel makes its way in and out of the bone. Okay? And what happened is actually the blood vessel was there first, and they laid bone down around it. Okay? Blood vessel doesn't really break through the bone. It was there first, and then we laid bone down around it. So as far as connective tissues, as far as bone tissue goes, it's very vascular. Okay? Broken bones get a good blood supply, so they heal very timely, 6 to 8 weeks, 4 to 6 weeks, roughly 6 weeks to heal a broken bone. Where tendons and ligaments are avascular. Okay? If you've got a favorite football team like the Cardinals, and somebody breaks a bone, they're going to be out 4 weeks. Okay, the bone will be healed at 4 weeks. It's whether or not they get their strength back, how long it'll take them to get back on the field. But if they have a high ankle sprain or they damage some ligament in their knee, that's a crapshoot. Okay, doesn't have a good blood supply. Some people come back in 4 weeks. Sometimes that's 8 weeks. Sometimes it's 10 weeks. Okay. All right. So macroscopic anatomy is not micro. Micro's small. You got to use a microscope to see it. Macro are the big things. So big things that we can see with the bone, the diaphysis. We called that, another word for that's the shaft. Good. And it's essentially in the long bones, it's a cylinder of compact bone. Okay. So the diaphysis or shaft of long bones is predominantly compact bone. There is just a little bit of spongy bone on the inside, but not much. So from outside in, the outer portions of the shaft, we pull away the shaft, you have a little bit of spongy bone, and then you're into the medullary cavity where the bone marrow would be, right? Okay. That cavity was lined with some sort of connective tissue that we called the, with an E, endosteum. Good. Okay, so marrow cavity lined with the endosteum. And so now, going back to my analogy here, this picture. Let's say this arrowhead wrapper, okay, was our periosteum. Plastic is the bone. This inner layer of this wrapper has a layer of what they call osteogenic cells. Osteo means bone. Genic means genesis. What's genesis mean? Creation. Okay? So these are cells that can lay down bone. They're trapped between the bone and the periosteum. On the inside, it's the same thing. Between the endosteum and the bone, there's osteogenic cells. That way we can lay down new bone next to this plastic. We can make it thicker, we can make it thinner, okay? So we have a layer of osteogenic cells on the inside of the endosteum and on the inside of the periosteum. Okay. All right, the epiphysis was the head of the bone, the ends of the long bones, and it was mostly what? Compact bone or spongy bone? Spongy, okay, so mostly spongy bone, thin outer layer of compact bone. And does the epiphysis, when you have a long bone, you have the shaft, and you have the epiphysis, the head, does the head tend to be a bigger diameter or smaller diameter than the shaft? Bigger, okay, good. So the epiphysis tends to be enlarged. Okay, oops, I'm going to put that down there real quick. Why is it beneficial to have the ends of the long bones to be a little more enlarged? You have more support, more surface area. So if I've got two bones coming together, I got one bone here, one bone here. If I have more surface area, that's going to make that a little more stable, right? Than if they came together like this. That wouldn't be very stable. Okay? So the other thing that this does, by having the spongy bone, we can make the area bigger diameter, but it's not solid like compact bone. It's spongy bone. So we can make it bigger, but yet lighter. Okay? So it doesn't add weight to the bones. Okay? Does that make sense? The spongy bone that look like coral, those little spicules, get laid down along stress lines. So how the bone feels like it's being stressed lays that down in a pattern to make it as strong as possible without having to fill it all in with bone. Okay? So now we've got more surface area for the bones to actually come together. We have more surface area for ligaments and tendons to attach to, right? If I had this come together and I was going to tape it together, I'd only be able to put one little thin piece of tape. That wouldn't be very strong. If I have it here, now I have a much thicker tape or ligament or tendon to help anchor it to the bone. That'll help make it stronger as well, right? Sure. Thank you. So strengthens the joint and allows better attachment of tendons and ligaments. So it basically just helps set up a better structure for these joints to come together and be stable, or as stable as they can possibly be. Because even when we say the shoulder can be dislocated, it's still fairly stable in the grand scheme of things. Think of how many times you've fallen in your life and you didn't dislocate your shoulder or your elbow or whatever. Okay? So this picture's trying to, we'll kind of show some of the stuff here. What bone is this? Femur, good. So we got the head of the femur, the greater trochanter, lesser trochanter, shaft. Shaft, this is the compact bone. Up here's the epiphysis, spongy bone. End of the shaft, hyaline cartilage. Down here, mostly compact bone. We don't even need to mention their spongy bone. Lined by an endosteum. Inside of that's the medullary cavity or the bone marrow. The outside, they've peeled it back right here. That's the periosteum. Little hole right there, little hole right there, little hole right there. Those are the nutrient foramina where the blood vessels go. So the blood vessels go in and run this way, or they go in and they run this way. Okay? All right, so you guys already told me we've got the hyaline articular cartilage. We have it on the ends of the long bones. We have it in the area of the epiphysis. Covers the surface of the joint, helps reduce friction. Okay, the hyaline cartilage plus what reduces friction? Synovial fluid. Good. Good. Helps reduce friction. Okay. So the bone on the outside is always covered by a connective tissue layer. All right, bone itself is connective tissue, but it's covered by connective tissue. It's either covered by the saran wrap, the periosteum, or on the ends with hyaline cartilage. Either one's a connective tissue, right? So periosteum covers the rest of the bone that's not covered by articular cartilage. And it's flat. They give it basically two layers. There's an outer fibrous layer, predominantly collagen fibers. It's continuous with the tendons. So however you want to look at it, the muscle comes down, its connective tissue bundles up, thickens up, and makes a tendon. That tendon merges into the periosteum. It's the same tissue, so it blends in. But then we get some fibers that actually go down into the matrix and penetrate into the deeper portions like it was stapled in there. And those were called what? Sharpie's fibers. Good. So we have the Sharpies, are perforating fibers that help anchor it there. They'll help anchor tendons, and they'll help anchor ligaments. Then we have an inner osteogenic layer on the inside. So the outer portion of the periosteum is the fibrous layer. The inside layer, the layer touching the bone, is the osteogenic layer, and that's where we're going to find the cells that create new bone. So these cells will help repair damaged bones, and they will help normal bones grow, either in length, but a lot of times in just diameter. Then you have another thing, depending on the age, you'll either have an epiphyseal plate or an epiphyseal line. Okay? This is the epiphyseal plate is the growth plate. It's that transition from bone to cartilage. If there's still cartilage there, the bone's still growing in length. Okay? Once the cartilage is gone and it's been turned into bone, there's no more cartilage, then the bone is no longer going to grow, and we don't see this plate, we see more of a line. Okay? And that's when they'll call it the epiphyseal line. And they've reached their full adult height at that point. Okay? So whether we see the plate or the line depends on the age of the person. So now we're going to look at some of these osteogenic cells. First one up, well, first we're reminding you where we find them. We find them on the inner layer of the endosteum and in the periosteum. Okay, so they're up against the bone. Endosteum, periosteum, and then whatever's touching the bone, that's where the osteogenic cells are found, which makes sense. You wouldn't want them on the other side. You wouldn't want bone, the connective tissue, the periosteum, and the osteogenic layers on the outside. You want them right next to the bone. Okay? And a lot of these are like mitotically active stem cells. Okay? They arise, or excuse me, they were stem cells, they were generic, meaning they weren't really specific to any one thing, and then something triggers some of them to change into some of these, a type of osteogenic cells. Okay? These cells are multiplying continuously, and then based on what's going on in the body, they'll either be very active or they'll be less active. Okay? And these cells can differentiate into osteoblasts. Some fibroblasts can also change and become osteoblasts. Osteo, once again, means bone. Blast is an immature cell. So this is an immature bone cell. Okay? These are the cells, the osteoblasts, that lay down new bone. Okay? So what they do is they produce the collagen fibers, they put calcium phosphate in there, and they watch it crystallize. That's how they lay down new bone. Okay? Produce the fibers, put the calcium in, watch it crystallize, harden, and that's our matrix, that's our bone. Okay? These cells respond to stress and or fractures in the body. So if you do not stress your bones, the osteoblasts aren't nearly as active. Okay? So when somebody is osteoporotic, okay, they supplement them with multiple things. They might give them, a lot of times it's females, a lot of times they'll give them estrogen along with it, but they'll give them calcium. Okay? But what do they also tell them to do? Weight-bearing exercise. You have to put some sort of stress to the bone, or the bones don't know where to put the calcium. They don't know where to rearrange the matrix and lay down those spicules of bone so that the bone's as strong as it can be. Okay? So if grandma is just taking her calcium medication but sitting on the couch watching Judge Judy all day, it isn't helping her. Okay? Now, grandma being old doesn't need to go do like CrossFit with you. She just needs to get out and walk and do simple things like that. But that'll help so that the body, the legs, the hips feel that stress. Gravity is stress, working against gravity, and we'll tell it where to lay down the bone, okay, the new bone, and make it hard. All right? So we've heard of osteoporosis, right? Your bones thin out, become brittle. They used to think grandma fell down and broke her hip. They're starting to realize now, no, grandma's hip just broke, and that's why she fell down. Okay? So these are the cells that will lay it down. You just hit the body, the stress tells it where to lay it down. So you have to supplement with the building blocks to build it down, but then the stress tells it where to go. All right. So osteoblasts form and mineralize the matrix. When they are done and they're no longer going to do anything, now they're no longer a blast, they're no longer an immature cell, they're now a site. Okay? So the cells that are done, that were blasts, become osteocytes, and then they don't do much as far as laying down new bone. But the osteoblasts do. They lay down the protein fibers, the collagen fibers, they put the calcium phosphate into it, and then it crystallizes to become hydroxyapatite. Okay? And it looks like alkaline phosphatase is what's responsible for that. Then they'll become osteocytes. The osteocytes become trapped in what are called lacunae, or little caves. And then from there, they'll signal each other through little tunnels, little gap junctions that were left behind called canaliculi. Okay? And they'll talk to the other blasts and or clasts that we haven't talked about yet about what kind of stress is being put through the bone and what the thought is and what needs to be done. So, osteoblasts have one thing they do. They lay down new bone. Okay? So if you bring an osteoblast to the party, it's going to lay down new bone. And what they do is, it'd be like if we brought an osteoblast in here and he lays down brick. Brick will be like his equivalent of bone. He comes in and he starts laying down brick, floor to ceiling, floor to ceiling, floor to ceiling, all up and back and forth, until the osteoblast is over in that corner and has bricked himself in. Okay? Now he's trapped. That little area that he left himself is going to be his lacunae. It's going to be his little cave. And he's no longer going to be a blast and laying down new bone. He's going to become an osteocyte. Okay? But he's going to be able to talk to other osteocytes through like the vent work. Okay, like the prison thing where they talk through the toilets and that type of stuff. I haven't been to prison, so I don't know. I wouldn't survive long. Anyway, so they communicate. So they're just sitting around, they're kind of watching things like, yeah, things seem a little weak or shaky here, and they'll tell other blastocytes to fix that, make it stronger. Okay, so a lot like a grandparent or whatever that's like, hey, you want to clean out the attic or whatever, and they sit down in a chair and they direct everybody to do this or that, kind of like my dad used to do. Okay, it was always me carrying stuff and him sitting there telling me what to do with it. Man helped me move a lot of times, never lifted a thing. So anyway, it's just giving direction to the other bones, because the other one's going to be the clast, the osteoclast. It can break down bone. Okay, so if there is no stress through the bones, and the body decides, hey, I don't have enough calcium here, they'll get signals to say, well, hell, don't worry about here, nothing's going on down here, and they'll break down some of the bone, freeing up the calcium that was put into the collagen fibers so that we can use it elsewhere. Okay? They kind of work together to make the bone stronger, because they'll break some down that don't seem to be doing well and lay it down in a new pattern that they think will be stronger this time. Okay? Does that make sense? So, the osteoclast is the second cell. It's a bone dissolving cell. These develop in the bone marrow. They're from stem cells as well. They're a large cell, so it's usually about 3 to 50 stem cells fused together to form one of these osteoclasts. and they reside in these bays called resorption bays. So here they're trying to show us a little bit of what this is like. We form this osteoclast, and it's in this little area, and it's just slowly dissolving bone. Okay? These can be told to become more active or less active. Okay? If they're less active, what they get dissolved will probably get repaired and laid down by the osteoblasts. Okay? Break down a bone with acid phosphatase. So alkaline phosphatase was what helped harden the bone. Acid phosphatase is what helps break down the bones. Okay. So what cell of osseous tissues are trapped in the lacunae? So once that thing's trapped in its cave and it's not laying down any new bone, it's a site. It's an osteocyte. Good. So once again, here's another picture trying to show us a little bit of this stuff. So here we have a humerus. They've cut a cross-section of the humerus off, and it looks like this. They pulled away a little periosteum over here. So this is the periosteum, and on the inner layer, these are the osteogenic cells. And they can lay down bone here or break down bone here, okay, on the outside of the bone. On the inside, we had the endosteum, and we have the same type of thing. We have osteoblasts that were here, and they laid down new bone and brought this from here to here. And we have these larger cells that can eat away the bone. Okay? And like we said, these bones are dynamic. They're always changing, so they're always being remodeled. And if you're stressing them, they lay it down to make it as strong as it can based on the information you give it. Okay? Does that make sense? Okay. So the matrix of bone tissue is 1/3 organic, 2/3 inorganic by weight. Okay? The inorganic portion are just the minerals. So the 1/3 organic, that's your collagen fibers. 2/3 inorganic are going to be minerals like calcium. Okay? Calcium phosphate. And this combination makes the bone strong and resilient. Okay? The minerals resist compression while the collagen resists tension. And I don't have a super analogy for this, but generally when you make a block wall, okay? So what they're talking about is they're talking about the collagen fibers, the firm, flexible, yet you can't stretch them collagen fibers, and then the minerals that get laid down around that. So it's a little bit like making a block wall at your house. What do they hammer into the ground and build the block wall around? Rebar. So the rebar is a little bit like your collagen, okay? And the block wall is a little bit more like the minerals, okay? And it's that combination, 1/3 to 2/3, that make it strong and resilient, lets it hold up. If it was just all minerals, it'd be hard, but it'd be hard like glass. It would be brittle, okay? And there's one of your pathologies that'll come up about that, okay? In fact, I think there was a movie about that, Unbreakable or something. M. Night Shyamalan ripped us off again, okay? So you can have that, or if you went the other way and you didn't have enough minerals, you had mostly just the collagen, then it would have the properties of the collagen. Your bones wouldn't be strong, they'd be like Gumby, they'd be real flexible. That wouldn't be good. Okay? So bone adapts and will vary these concentrations to match the tension and compression that's put through there. But it doesn't, and we're talking about small variances in this, okay? It's basically 1/3, 2/3. It never goes to, well, it's 25%, 75%, or 1/4, 3/4. It stays right around that 1/3, 2/3, give or take a little bit, but it does vary it, okay, based on, once again, the stress you put through your bones, okay? So the organic portion was the collagen fibers and some of those things that we found in the ground substance last unit. Do you remember the 3 things that made up the ground substance last unit? Glycosaminoglycans, proteoglycans, and adhesive glycoproteins. Good. So it's those same things, okay? The inorganic component are the minerals, 85% of which is hydroxyapatite. okay, which is primarily what? Crystallized calcium phosphate, okay? 10% is calcium carbonate, and then there's some other minerals. You will find magnesium in there, fluoride, sulfate, potassium. We do store other minerals in the bone, but as you can see, 95% is calcium in some form. The number one form is calcium phosphate. Okay, doing all right? I know this is a very dry subject. Okay. Compact bone histology. So the structural unit in compact bone and the long bones is called an osteon. Okay? Some books, you can jot this down, I use osteon. Some books use what's called Haversian system, like it's Haversian, Haversian system. Okay? Same thing, so I just don't want you to get confused if you guys look at a book and you see something different. It's the basic structural cylinder of bone. Okay? It's in compact bone, it's in long bone, so we find it in the diaphysis. It runs parallel to the diaphysis. It's made up of different layers, almost like rings that we call lamellae. Okay? So different layers of matrix being laid down in different orientations around what's called a central canal. That central canal contains blood vessels, an artery, a vein, nerves sometimes, and they were there first. And then, in a nutshell, to try to make this as simple as possible, that's running down the shaft of the bone, and we actually lay down bone, but we lay it down in rings around that blood vessel, okay? Because the blood vessel was there first. So that's how we keep bones vascular. The collagen fibers in each layer are oriented in a different direction. They're oriented based on the stress at that time. Okay? So we've talked about the stress put through bones tells it how to lay these things down. And so it lays these fibers down in a certain way, and then it calcifies them to make it as strong as possible. And if we, just like dense irregular connective tissue, the more we had collagen fibers going in random directions, but basically lots of different directions, and it made it strong in lots of different directions, right? So if we have the layers, each lamellae, the collagen fibers being laid down in a different direction, that'll make the bone overall strong with forces from different directions, right? Okay. We have little cytoplasmic extensions that run through these rings called lamellae, and these are the canaliculi, and they connect osteocytes to each other and their blood supply. So when we had that osteocyte trap himself over here in the corner, he needs a way to get his nutrients. So he gets it through the vent system. I mentioned talking to each other through the toilets, so whatever. Any little opening that it has, nutrients will make it to and from, and that's also how they communicate. Okay, and that was called the canaliculi. Actually, there's no such thing as canaliculi. I just made it up. You guys don't know that I'm making it up. All right. So, perforating canals. So these central canals, we have a central canal running this way. We wrap layers of bone around it. That's an osteon, okay? And they run parallel to the shaft. Now, some of these osteons have to be connected to each other, and so they have a canal that goes perpendicular to the shaft, and they call them perforating canals, okay? They also call them Volkmann's canal, perforating perpendicular Volkmann's canals. So some guy named Volkmann wanted his name tied to this. And they're simply canals that connect two central canals together. So we've got a blood vessel running this way, we've got a blood vessel running this way, and somewhere there might be a blood vessel connecting the two. It ran in a Volkmann's perpendicular perforating, canal. lamellae. We have what are called concentric lamellae. So let's see if any of these markers work. If I have a blood vessel running this direction, okay, maybe another one running here, and so we're in some part of the diaphysis, okay, and I put a ring around it of bone, okay, that's a lamellae. If it goes around a central canal, it's a concentric lamellae. And I can have another ring around the outside of that, and I can make it thicker yet and outside of that. These are all concentric lamellae. Okay? This would be an osteon then. Over here, we have the same thing. Over here, the same thing. If I take a group of these osteons and I wrap connective tissue or bone, put a layer of bone around the outside of those, that's a different type of lamellae. Okay? That's called a circumferential lamellae. So concentric lamellae go around a central canal. A bunch of osteons together with bone wrapped around that, or laid down around that, or wrapped around that, laid down around that, would be called circumferential lamellae. Okay? And then anywhere we just had to fill in cracks and crevices, we do that with what's called interstitial lamellae. And so I've got a picture coming up. Hopefully here I'll be able to show you, because I just looked at my picture again and that probably didn't help. So, some things we can see here. This is a microscope slide of the bone. So they've cut off a piece of bone, laid it flat on its side, so this is coming out at you. In the center, we have a central canal. So out of that, there'd be a blood vessel coming at you. Okay? And you can see 1 lamellae, 2 lamellae, 3 lamellae, 4 lamellae, layers of bone wrapped around that, right? Those would all be concentric lamellae. These little black areas right here, these are space, space, little space, space, space. Those spaces you could also call cavities, caves. So who's hiding out in there? Osteocytes. And the little bit that looks almost like somebody came by with an eraser and tried to erase it, and you see like little dark lines going these directions, those are the gap junctions. Those are the canaliculi that allow them to communicate and get nutrients from each other, get nutrients to each other. Okay? This whole thing is a picture of an osteon. Okay? So we'll go over here to this picture. Here we have a central canal. We have blood vessels and nerves running parallel with the bone, and you can see here a ring around it, 2 rings around it, 3 rings around it. Okay? This whole thing's a what? An osteon, right? These lamellae here would be concentric lamellae. Good. So this was an osteon. Here's an osteon, and they pulled up each ring just to separate them out. And I don't know if you can see it well enough, but can you see the collagen, the orientation of the fibers? This one they're running this way, this one they're running the other way. It changed. It did that because of the stress to make it as strong as possible in multiple directions. So now we've got 1, 2, 3, 4 osteons. Out around here, these rings wrapped around all of them are lamellae as well, but they're now called circumferential lamellae. Okay? And then you're thinking, okay, what the hell is an interstitial lamellae? Well, see, like right here where it almost forms a triangle, it's not part of a concentric, it's not part of the circumferential, that'd be interstitial lamellae. Okay? Periosteum, osteogenic cells would be in here somewhere. This is a, what would this be right here, this canal? Perforating, yeah, you get 3 options, perforating, perpendicular, or Volkmann's canal. There you go. Read the shit off the screen. I don't know. I'm thinking, wow, you guys really learning this. This is awesome. I'm going to go home. Not going to drink myself to death tonight. Think, oh my God, I made a difference. And see, now you just shit on that. So now I am going to go home and drink myself to near oblivion. I may do it before lab. Anyway, lab's boring. All right, so we doing all right? Okay. Here's another picture, same thing, just to give you visuals. I like visuals. Sometimes the ones they give are like overwhelming, but this is a pretty good one. Once again, concentric lamellae, concentric lamellae, concentric lamellae, all around a central canal. So this whole thing's an osteon. They're showing you the fibers going in different directions so that it's strong in multiple directions. And if we took several of these, bundled them together and wrapped bone around the outside of that, those lamellae would be the circumferential. Okay? Here's a little bit of what that spongy bone looked like. That's that coral. Okay? A little bit of compact bone on the outside, a little bit of compact bone on the inside. The nice thing with spongy bone, it's not as dense, so it's not as heavy. But these little spicules, it looks random to us, but are laid down around stress lines as well. So they're as strong as it could possibly, as the body could make it based on the information it was given at the time. So spongy bone, sponge-like appearance, describing it that looks like coral is a good descriptor. Okay? Books will refer to it as rods and plates, or a lattice work. A lattice or a trestle, those are the things outside the house, those little white things that are like woven, that women want you to plant viney stuff to grow up so that you can spend half your life trimming it, because they're not going to trim it, so it's not a big deal to them. Just kidding. You guys probably do a lot of that work too. Anyways, these spaces are filled with red bone marrow. Totally different than the compact bone setup and the diaphysis, so we don't have very many osteons, we don't have central canals. The osteocytes are close to the bone marrow themselves. This bone marrow is going to be in these little spaces, okay? So they'll just absorb what they need from the bone marrow. And like I said, it provides strength, but it's lightweight. Those rods and plates develop along stress lines, therefore they're laid down in such a way to make it as strong as they possibly can. Last slide is the bone marrow itself. All right, so this is an adult, and they're showing you the places that you can find the most red bone marrow. You're going to tend to find it in the flatter bones. Okay, long bones in children have lots of red bone marrow. Adults, these start to fill up with what's called yellow marrow instead. Okay, so medullary cavity of the long bones is where we can find the marrow space, and or the spaces in between the trabeculae of the spongy bone. Red marrow looks like thick blood. Okay? There's a fiber type in that marrow cavity that helps draw the blood and hold it there. What fiber type might that be? Would it be collagen fibers? Elastic fibers? Reticular fibers? Reticular fibers? I'm going to go with reticular fibers. Okay, remember they drew water, help hold it there? Okay, that's kind of what's happening in the marrow. It's holding kind of the blood and the blood cells there. So it's a reticular fiber meshwork that helps draw and hold the blood. This is where red blood cells develop. So would you expect to find more immature red blood cells here than the than in the circulation, or less? More. Okay, so lots of immature cells found here. Immature red blood cells are called reticulocytes. Mature red blood cells are erythrocytes. This tissue is said to be hematopoietic or hemopoietic, okay, because this produces these cells. The medullary cavities of the long bones transition into yellow marrow of the adults. It's more of a fatty marrow. Okay, and if the body's in a time of crisis, okay, some of that yellow marrow can change back to red marrow to produce more red blood cells. Okay, so yellow marrow can differentiate back into red marrow in a time of crisis. Enough stress to the body will make that change. When you get to be elderly, you go from yellow marrow to gelatinous marrow. It's the marrow found in bones during old age, and it's kind of a reddish jelly, and there's no switching it to yellow or red marrow. Once it's gelatinous marrow, it's dead in the water as gelatinous marrow. So that's it for today.